You know, in healthcare, we've sadly had this issue with silos. Private versus public. In hospitals, it's surgeons versus medical, it's admin versus clinicians, it's nurses versus doctors. And COVID was a great leveler because it just taught us that if we work in silos, we are not in the best position to leverage the strengths of everyone on the team. And it was really heartening to see that in India, the silos between private and public healthcare were broken during COVID, because if we look at the way the care delivery was done, about 60% of all the ICUs, ventilators were in the private sector. When it came to labs, it was half and half. When it came to vaccination, it was 90% government, 10% private. But I think for the first time, we broke these barriers, and I think we have all benefited from this. And in keeping with the future, the expectations that patients have, we have to break these silos. To discuss that, we have a very stellar group of experts, and I'm going to, along with Samir, moderate this. So what we're going to do is going to request each of our panelists for their opening remarks, and then we'll have some questions directed at them, and if there's time, then we'll do a Q&A. We're going to start with Dr. Rakesh Gupta, who is an internist by training, trained in Rohtak, and then went on to establish a very successful practice, and then created the Sarvodaya Healthcare Group out of Faridabad. He's chairman and managing director. So, Rakesh ji, for your opening remarks.
Thank you for inviting us at this CAHOCon. The idea is that it has to be collaborative practice. There are silos are there. The doctors are not talking to nurses. Nurses are not talking to technicians. We are not talking to each other. Even in a particular patient where there are multidisciplinaries involved, 2, 3, 4 doctors are not talking to each other. Then the patient is getting treated in silos, and hence the complications. The idea is to get them together. For example, in our accreditation committee meetings, the NAVH committee meetings, what we do is that, for example, in HIC meetings, we'll hold a small brainstorming session together. We get the messages out over there. And then we call a larger forum like this and discuss the things with all the stakeholders, so that then we are not working in silos. Everybody knows that what is being planned, what needs to be executed, how to take care of the patients in a multidisciplinary way. And then they can perform their own roles within the system. That is one thing which we do. Especially, secondly, that we have multidisciplinary team rounds on the floors itself, as well as in the ICUs, where the patients are complicated. To break the silos, we need to get together and create a platform within the hospital where everybody can raise their opinion, give their suggestions, and the execution is done in a combined manner. That's my idea. Thank you.
Thank you so much, Rakesh ji. And from Faridabad, let's go to the beautiful islands of Japan. We have Dr. Shin Ushiro, who is the director of the Division of Patient Safety at the Kyushu University. He's very actively involved with the Japanese Council of Quality in Healthcare. He's been a board member of ISQA and is a member of the G20 Patient Safety Leaders Group. I've had the privilege of working very closely with Shin at the World Health Organization. Shin, your opening remarks.
Do you want me to make a comment on inclusion of patient?
Yes, please.
Okay, thank you very much. Yes,
could you just use the microphone slightly higher so that we can, because there's an echo. Yeah.
Okay. Thank you very much. I'm Dr. Shin Ushiro. I'm from University Medical Center, as well as accreditation body in my country. I'd like to focus on my experience in my hospital. First, we have a organizational structure to promote patient safety. For instance, we have division of patient safety. We have division of patient consultation. Those divisions collect patient voices, and those divisions collect data such as PROM and PREM, patient satisfaction, patient experience. And we also conduct the regular meeting with patient representatives. It is called Patient Safety Audit Committee, regulated by the government. And we communicate with the patient, and we incorporate outcomes into the improvement action for patient safety. And shared decision making that Dr. Ezekiel, the president of the ISQA, mentioned this morning is quite important. When you make shared decision making, informed consent document form is quite important. In my hospital, we conduct standardization of informed consent to see if the consent form includes items necessary for explanation or the graphic figure for better learning for patients. And the medical chart disclosure is also conducted in my hospital. So there are a lot of confusion and misunderstanding between patient and medical professionals. So the disclosure of medical chart is quite helpful. And all those items are included hospital accreditation that my accreditation body provides. So going through accreditation is quite helpful. And when you go through accreditation requires you to produce patients' rights, so which is very helpful. Last year, WHO released the Patient Safety Rights Charter. So you may want to incorporate those patient safety rights charter. There are 1 to 10 items into your patient rights in your hospital. So those are I will stop there. Those are the activities and practices we have been conducting in my country. Thank you.
Thank you, Shin. From Japan, let's go down to Bangalore to Dr. PM Uthappa, who's a distinguished nephrologist, worked in England for a very long period of time, and then did the most sensible thing is to come back to India as we move towards our journey to become developed by 2047. He's the group medical director of the Narayana Health, and in addition to his role as a clinician, as an administrator, he also loves to run marathons and has completed the Ironman. So lots of admiration for that.
Thank you.
Your opening remarks, please.
Sorry, I didn't get the last bit.
Your opening remarks in terms of what do you feel in terms of breaking silos?
Yeah. I'd just like to go back to Narayana Health. We have around 20 hospitals, 25 managed care clinics, and now an insurance arm. So that means we have to see how the entire ecosystem of quality, safety, and governance works. So a couple of years ago, we started from a very blank page. We thought, how do we make sure, we had two pressing problems. How do you make sure everybody follows guidelines and protocols and SOPs? And how do you make sure all our hospitals are aligned to do the same thing? So we created a very nice monitoring, measuring, analytic platforms, which helped us bring in some kind of uniformity across the group. And this was part of something called clinical governance. As one of the highlights of this topic is working in silos. What this governance framework does is it makes sure that every stakeholder in the hospital, whether it's a dietitian, frontline, the person manning the desk, or some ER physician, clinician, nurses, they're all part of the governance, and it's all calendarized and regularly monitored, measured, and analyzed to get some insight. So what happens with this is every month we go back and discuss this, and that's setting a culture where it's music to our ears now. When you go and speak in the hospital, the doctors talk about governance, doctors talk about quality, doctor talks about safety. So the key thing here is the measuring, the monitoring, and the analysis, being very consistent, going back and doing it all the time. Just to give one example, not very popular, but it's very important. A few years ago, our ALOS in lap cholecystectomy across the group was roughly 3.7 to 4. That's very high, you all agree? One of the hospitals, our hospitals, Narayana in Gurugram, the best ALOS was 1.5. So as I mentioned, we monitor on a regular basis. Every month this was shown to all the doctors across the group. And now, after 2 years, our group average has come down to 2. So that's the power of measuring and monitoring, being very consistent and going back and showing to them, this is how we do it. There's lots of other examples, probably in view of the brevity of time, I will just skip that. Thank you.
Thank you so much, Dr. Uthappa. I'm going to now invite Mr. Prashant Sharma, who's the Managing Director of Charnock Hospitals, part of the SKM group in Kolkata, for your opening remarks. What I want you to specifically cover is, because you're not medical, what is it from the other industries that you believe we can kind of learn and incorporate in our functioning?
Thank you, Dr. Anupam, and it's a pleasure to be here as always. Healthcare is part of the services sector. If you look at the services per se, there are multiple other industries or sectors which are participant in this. So we are a sort of a consumer service, whether it is other sectors, whether it is travel, whether it is airlines, whether it is airports, it is malls, it is education, it is hotels. These are all service sector industries. And healthcare, private healthcare in India started in the 80s, where Apollo came with one of the first hospitals. There were some hospitals before that, but the larger movement started around the 80s. So per se, we are about 50-year-old in the services sector. And since the last 50 years, we've been trying to evolve different models which will perfectly fit what is required in our country. The larger traction we can see is over in this current century, where specifically in the last 15 years, a lot of private action has come into private healthcare space in the tertiary quaternary space. Most of this is fueled by private equity infusion. And once the private equity infusion comes in, they also bring along with them a lot of global practices, because most of these private equity firms are global in nature. But let's take a step back and look at other sectors, what they are doing. Look at our airports. The kind of airports which we are building in our major cities are much bigger, much better, much more sophisticated than most of the rest of the world. When I say rest of the world, I mean the western part of the hemisphere. So if you compare our hospitals, our airports with the airports perhaps in the northern American continent and other things, we can see it's much more efficient. The service levels, the way it is being built, the kind of volume it can handle is much more better than what has been done in the past. Similarly, in the hotels, if you look at the hotels in Asia, they are much more modern, more adept to today's requirements. Whether it is in India, in China, in Southeast Asia, our hotels, volume-wise, size-wise, is much bigger, better than what has been done in Europe, what has been done in USA. So I think this is a great opportunity for us to learn what has been done in airlines, in aircrafts, in airports, in hotels. A similar opportunity also lies in healthcare. We having a population touching 1.5 billion very shortly, also catering to some MVT. We have the opportunity to design healthcare in a very dramatic fashion, which will cater to the requirements not only of today's India, but tomorrow's India. And also taking a leaf out of learning from the IT services, what IT has done for India in the last 40 years, 30 years, whether it is a TCS or the larger companies, how they have completely transformed the way things have been done, not only servicing Indian sectors, but also overseas. So I believe that healthcare also has a similar opportunity to transform itself, taking learnings from multiple of these sectors and incorporating them, re-engineering itself, redesigning itself to cater to today's India and tomorrow's India.
Thank you, Prashant. I'm now going to request Mr. Negi. Mr. Negi is an IAS officer of the 1975 batch, many positions across different departments. In fact, he was the Principal Secretary of Health, Government of NCT, and used to sit on the board of Apollo Hospital as well. And then in 2007, and I have to say he would be definitely the longest serving CEO of a hospital, because he's been CEO of Rajiv Gandhi since 2007. So Mr. Negi, in your two avatars, one as a senior IAS officer and then as a CEO, what are the differences that you found in terms of healthcare? Because when you first entered healthcare, you would have been surprised to see the kind of regimentation, the kind of silos, and what were the learnings that you brought from the IAS into Rajiv Gandhi, which others can possibly learn from in terms of breaking silos?
Thank you, Dr. Sibal. It's a very relevant question. I spent about 35 years in the IAS and here 18 years in the health service. Now almost forgotten what IAS is, what administration is, but I mean looking. Only difference is when we were in the service, by and large, we were looking from a macro level, what's happening in the field, But once you come to hospital, then you have the opportunity to go through the micro issues there. which is very critical, very important, and which probably we missed in the service. So it's a great experience, and you're talking about the silos. I think is very critical. In fact, the silos in the health sector are fine. Is a steel silos, very difficult to break. I think we need to break it because it is ultimately in the interest of everybody, the patient, their families, and also the the care providers. So because what I always talk about is the cost. In the hospital, we find, especially in the cancer hospital, people coming from different walks of life, different economic backgrounds, social backgrounds. They have no alternative because they don't have the insurance. So they have to spend out of their own pocket. In many cases, I find that they sell their, the family silver, whatever they have. They sell their small piece of land because they think, that sometimes that life is totally eternal. So whatever amount of counseling you do it, but they always try to spend whatever is possible to them so that the patient survives. So the patient is not only physically traumatized, or the family is not only physically or mentally traumatized, but also financially traumatized. So I think the biggest the challenge to the health sector is how do we really keep the cost low. I think this can be kept low by breaking the silos, because we can have some sort of partnership hospitals. Why every hospital, for that matter, having cancer, the cancer hospital everybody should have a Linux. Why not have one hospital Linux and others use it? Like, for example, digital transformation. I think the hospital spends crores and crores rupees on the platforms. Why can't we have a common one and try, bring down the cost? I think these are the major issues, and this can only be done. It is really generally we have the intention to have collaboration. Otherwise, we'll keep on prying on each other. We'll all trying to poach on each other, and this will really never help. So I think keeping the cost in the health sector is a major challenge. Otherwise, affordable apart, it may not be sustainable to many hospitals. After all, when the health inflation is at 14%, how many people can survive? Even the insurance people cannot survive. So I think this is the major challenge for everybody. We need to break the silos, and for the larger interest of everybody. So with these words, thank you very much, Dr. Sibal, for giving me this opportunity.
Thank you, Mr. Negi. We apparently have about 5. How many minutes? 5? Okay. Or either we can do that, or maybe we have some very brilliant people in the hall. Maybe we can ask if anyone has any comments or questions. We have 4 or 5 minutes to go. While we are waiting for anyone to come up with, Somji, if I might actually, if ask you for your comments. And the reason why I ask is, if you look at the global positioning of India and you go anywhere abroad, sometimes you get into a cab and the cab driver will say, are you an IT professional? If you go to the Midwest in the US, the whole impression about India and the way the world perceives India is very driven by how India has been successful in IT. And of course, you've played such a stellar role in how India has emerged as a global leader in IT. Based on your huge experience at NASSCOM and in different industries, what is it that you saw? And we are privileged to have you talk about patient safety. But what is the advice that you would give to us in healthcare on how we should reimagine the future and finally get rid of the silos that exist? I'm just going to come and give you a microphone.
Thank you so much for this opportunity. I think we've got stalwarts here, and you did mention about the IT sector. I think one thing which is really common between healthcare and IT is us people, right? So I think at IT, there is nothing else but people, right, who are software engineers or people who work hard. And similarly, when you look at healthcare, technology is common, whether it's US, India, Japan, we can get the same technology because technology is to buy. The difference is in people. I think what we did in the tech sector was educate people, continuous learning. And this is, I'm not confusing it with CME. CME is a necessity, but I think skilling people, reskilling people, changing technology, and how you did that. In case of the IT sector as well, I think the turnover is very high. We created processes which were changing constantly, but were repeatable, right? So the first country that did a CMMI level certification, and by the way, it's very different from the way accreditation happens here, right? They one by one, so we moved from CMM 2 to 3 to 4 to 5, and India was the country which had the largest CMMI level 5 certification in the world. Customers used to come to us and saying, hey, you know what? I run a big software company in the US. I'm level 3, you're level 5. Show me what are you doing. So it wasn't an audit that was done periodically, it was any time. So I think what the IT industry is was we were never ever preparing ourselves for an audit. It was any time. You don't prepare for a cyber security audit. You have to do it every day because in between audit, you're going to be affected. So I think we're on the right track. We have people, we have hospitals, we have colleges, but I think we need that commitment that we can all do it. I think we are on the track, but I don't see any reason where tomorrow the cab driver or the immigration officer in US is going to say, "Ab healthcare ke ho gaya." Thank you.
Absolutely. Thank you, Somji. Thank you for that. Yeah, that day is not far. We are producing 107,000 MBBS doctors, going to go up to 120,000 a year. All of Australia has 100,000 doctors. So eventually the shortfall of the 3 million that the World Health Organization predicts by 2035 is going to have to come from a country like India, where English is the spoken language and is the language of communication for healthcare training. But great point, Somji, and I think a lesson, and I guess in the debate yesterday, we talked about those 5 days versus the 360 days that you should be ready for accreditation. But very importantly, you said it's not about CMEs, it's about continuous education. And clearly there is a void when we look at us in healthcare in terms of communication. We might be very good at communicating the medical bits, but the whole communication and actually changing the way the patient today perceives healthcare and their expectation is, I think, a huge area where I think we can all improve. We now have to bring this to a close, but I'm going to ask any of our panelists for their final comments.
So before we wind up the session, could I request the other 4 panelists to just give a 2-liner or a 2-pointer message or a mantra? How do you wish to break the silos across departments, across industries? We'll begin with Dr. Rakesh Gupta, sir.
I have already emphasized the role of multidisciplinary meetings, especially the NABS committee meetings, which are held in closed doors, and the message doesn't get across to all the stakeholders, especially the people who are the real caregivers, whether they are from the CSSD or they are the nurses or they are the OT technicians or anybody else. That is one important element to break the silos. It is on a micro level of force, definitely agreed. So we should have platforms of this such kind. Similarly, in the ICU, what we feel is a patient is seen by a number of doctors. A doctor X comes, prescribes something, talks to the family, writes 4 references, A, B, C, and D. Person B comes, and then without consulting the primary person, he starts talking to the family and advises 4 more tests, which are now getting more complications done with the patient. So we need to break these small silos. It is all the way at a micro level. I fully understand that breaking silos at macro level would be different and micro level will be different. But clinically, micro is very, very, very important because that ultimately impacts the patients in an adverse way. It may impact. And once it's taken care of, it can then improve the clinical outcome in a very, very nice manner. With these words, I thank the organizers for giving us this opportunity at CAHOCon. Thank you.
Thank you, Dr. Gupta, for gracing the occasion. Dr. PM Uthappa, sir, question to you. 2-line mantras or 2 messages.
Thank you. Thank you. I just want to go back to what Anupam was talking about. The rest of the world, India is famous for IT. No, it's also famous for doctors. Whether you go to UK or any other English-speaking countries, lots of Indian doctors are very revered and respected. And why do these doctors thrive in these countries? I worked in England for 20 years. It's one simple reason. It's not that we are less hardworking here or more hardworking there. They work within a framework. They work within a system. They follow the rules. And there are systems. The challenge we have in Indian healthcare systems is we do not have processes. We do not have proper regulatory methods. And nobody works within those frameworks. So safety culture is not built in a day. Safety culture is built every day, and through proper leadership. So I suggest that we need to have proper mechanism to regulate or have proper processes, guidelines, and make sure that these doctors and healthcare workers work within the system. I think just talking to them or doing CMVs or saying, "Oh, look after the patient well," it's not going to work. It has to be enforced and asserted. Thank you.
Thank you, Dr. Uthappa. Mr. Prashant Sharma, just 2 pointers, 2 messages.
To continue learning from other industries and incorporating them in our sector. For example, from hotels, we can learn property leasing models. They have amazing property mechanisms. We can learn people management. You take out one room division clerk, put him in another hospital, he will do the same thing. Take out one GM from one hotel, put him in another hotel, he will do the same thing. But in our sector, we are very, very people dependent. We are not very much process dependent. We can't replace people that fast. So I think growth of people and people management is what we can learn from hotels very well. From airlines, I would say we can learn equipment leasing models. They have dry lease, they have wet lease, they have damp lease, they have moist lease, all sorts of advanced leasing options. We can learn from there. We can adopt in our healthcare ecosystem for equipments and machineries, which are very capex heavy. We can also learn efficiencies, because for one aircraft to leave on time and arrive on time, there are a million things which have to go right to make it happen. In our healthcare also, there are dynamics. The dynamics are quite similar, and we can learn that from airlines and probably incorporate that so that we can have minimum failures possible.
Thank you, Mr. Sharma. Dr. Shin, Ushiro, 2 messages or just 2 words, which is your summary take?
Okay, I'd like to highlight with 2 words. The first word is leadership. In my country, when a hospital director is selected, he has to have or she has to have experience on patient safety. So leadership involving other stakeholders is quite important. Another topic is a periodical evaluation by stakeholders. I mentioned patient safety audit committee in the presence of patient. So the periodical assessment is quite important for improvement. Thank you very much.
Thank you so much. I think in summary, the take-home message is break the barriers of departments, break the barriers of industries, and learn from them. But I think the most important is break the barriers of your mindset, be open to adopt and learn and adapt. Thank you all for your time. I would request all the speakers and the chair to please